Hello and welcome to this online EMT course on pathophysiology. This is the third installment of the 5 sections on this topic. In part 2, I covered the basics of ventilation and a few of the potential issues that can compromise efficient movement of air into and out of the body. In this section, we're going to get into some of the more complicated concepts associated with ventilation, including the mechanisms that regulate it and the various measures of ventilatory sufficiency. Oh boy, let's get started. Hopefully you recall from previous lessons that individual gases move between the lungs, the blood, and the cells due to diffusion. Oxygen enters the lungs where it then diffuses into the blood. It's then transported throughout the body. When it reaches a capillary bed, the oxygen moves into the cells, since there's more oxygen in the blood than in the cells. Carbon dioxide is created in the cells due to the chemical reactions that occur there during the energy production phases. CO2 will move in the opposite direction, again based upon the imbalance in concentrations between the various compartments. As you can see here, there's more CO2 in the cell than there is in the bloodstream, so it moves out of the cells. I'm hoping this illustration helps you to visualize these concepts. Now, based upon the necessity of oxygen for cellular health, you might assume that oxygen levels drive ventilation and how fast we breathe. Unfortunately, you would be wrong. It is in fact the amount of CO2 that our body monitors to determine if ventilation rates need to increase, decrease, or stay the same. The reason we use carbon dioxide to influence ventilation has to do with acid-base balance. The body is very susceptible to changes in pH, and these controls are in place to keep it in check. You see, when CO2 enters the bloodstream, it binds with water in the blood, and it forms an acid called carbonic acid. Therefore, when CO2 levels rise, more acid is formed. To avoid this, ventilation rates increase as CO2 levels rise, so we can blow off this excess CO2 to avoid acidosis. Okay, so how do we monitor the levels of CO2 in the blood? Well, we have specialized chemoreceptors, and they're located here in the brain, in the aorta, and in the carotid arteries, and they constantly measure the CO2 levels and the pH in blood. When the CO2 levels rise, more acid is formed, and that results in a drop in the pH. Yes, the more acid, the lower the pH. Sensors will then send a signal to the brainstem, which responds by increasing the breathing rate. This allows us to more quickly remove the CO2 that's returning to the lungs, and the levels in the blood drops. Now, when the levels return to normal, a signal is then sent to reduce ventilation. This is occurring hundreds of times per day. Our rate of breathing is constantly increasing and decreasing based upon the levels of CO2 that are being produced in our body. Now, this is an awesome system, but guess what? Sometimes it breaks. The most common reason it fails is that we do something we shouldn't be doing and we break the mechanism. You see, some people always have elevated levels of CO2. This is generally due to lung damage that reduces the effectiveness of CO2 removal. That lung damage is almost always caused by smoking. We call these chronic obstructive pulmonary diseases. Or COPD for short. You're going to learn more about these issues later in class. But what happens is the system tries to work, but since the CO2 levels remain elevated due to these lung diseases, Ultimately, the body will just going to abandon monitoring CO2 and it swaps over to monitoring oxygen levels. We call this hypoxic drive. Now, in this case, the receptors look at O2 levels. When they drop, they send a signal to the brain to increase breathing. When the O2 levels rise, they send a signal to slow the breathing back down. Now, this backup system has a big potential problem. First, if we give our patients a lot of oxygen, the O2 levels in the blood rises very high. This overabundance of oxygen could conceivably result in a serious decrease in ventilatory rate. That's why we're very careful when we give oxygen to COPD patients. Okay, now we're going to dig a little deeper into this pulmonary function stuff by looking at some of the measures of ventilatory function. Now, in the field, we don't exactly measure all of these things in specific quantities, but we do look at them in more of a general sense. For example, we might not measure volumes directly, but we do observe to see if a patient's breathing shallow or if they're breathing deep. Well, here are the measures. Tidal volume. This is the amount of air moved during one ventilation. If you actually measured it, you would find that a normal resting adult only moves about 500 milliliters of air with each breath. Now, tidal volume varies depending upon metabolic needs. So that same adult might move 1,000 milliliters of air if they're exercising. Always remember, consider the patient's activity level when assessing tidal volume. It would be very abnormal for someone at rest to be huffing and puffing like they just ran a marathon. The next measure is rate, and this is one that we do measure. It's simply how many times a patient breathes in 1 minute. Now, often we'll just count for 15 seconds, then we'll multiply by 4. Now, that's okay sometimes, but if your patient's having difficulty breathing, it's actually best to count their ventilations for an entire 60 seconds. The next measure is minute volume. This is how much air a patient moves in 1 minute, and it's actually calculated using the previous two parameters. Minute volume equals tidal volume times rate. So, if our typical patient has a tidal volume of 500 and they're breathing 10 times a minute, well, that means their minute volume is 5,000 milliliters, right? 500 times 10 equals 5,000. Okay, now you're asking, but why is this important? Well, it's important because it helps me show you that if we need to move more air, for example, let's say we have a buildup of CO2, then we can actually do a few things. 1, we can increase the rate. 2, we can increase the volume. Or if the poop is really hitting the fan, we can actually increase both. And that's what we often observe in our most serious patients, an increase in both rate and depth. All right, now you've noticed we're getting pretty deep into this function of the pulmonary system. Well, hold on. We're now going to get into even some of the more complex material. Remember tidal volume, the amount of air we breathe in one ventilatory cycle? Well, it turns out we can't use all of that air. You see, our pulmonary system actually contains 2 compartments. Check out this illustration. First, we have what's known as dead space. This is the pipes and the airways. And in this dead space, there is no gas exchange. The other compartment is the alveolar space. We find it down in all these little clusters of alveoli here. The air that reaches way down here is available for gas exchange, and that means that the oxygen in this air is usable. Now check this out. We can measure these volumes. Dead space volume never changes, It holds about 150 milliliters of air. Alveolar space does change depending upon how deeply we breathe. So in that normal resting adult, it's about 350. Now I calculated that by taking the normal tidal volume, 500, subtracting the dead space, about 150 milliliters, and I get 350 milliliters. What this means is I can only access the oxygen in that 350 milliliters of air. All right. I know you're asking, so why is this important to me? Well, here's the reason. Suppose your patient is sick. They're having trouble moving air due to some pulmonary complaint. If that occurs, they may have very shallow respirations, and that translates to a decreased tidal volume. So let's say our patient's tidal volume drops to 350. Well, that means they only have access to oxygen in 200 milliliters of air. 350 minus 150, the dead space, equals 200. That's why we must look not only at a patient's breathing rate, but also at the depth. And you're going to learn in class that sometimes we assist ventilation in patients who are still breathing because they're breathing too shallow. We don't necessarily wait until they stop breathing to support ventilation. Okay, we're not quite out of the woods yet. Another somewhat complex process I need you to understand is that it takes time to breathe. Now let's look at how this can dictate our treatment. It turns out it actually takes longer to exhale than to inhale. Trust me, it has to do with muscle work and some other complex stuff that we don't really need to get into. But it turns out it takes about twice as long to breathe out as it does to breathe in. This is referred to as the inspiration to expiration ratio, and it's denoted IE. And as I just said, normal IE is about 1 to 2. It takes twice the time to expire as it does to inspire. All right, now let's do a little math. Breathe in. No, really, take a breath. How long did that take? About a second? Well, if we use this normal IE ratio, if you breathed in for 1 second, that means it's going to take 2 seconds for you to exhale that same volume of air. Cool, huh? All right, now let's take it a step further. Let's say you're breathing in and out without pauses. That means each ventilatory cycle is 3 seconds. 1 second in, 2 seconds out. Well, you know what? That means you can only breathe 20 times a minute. 60 seconds in a minute divided by 3 seconds per breath, and if you do the math, you'll see that that's 20 breaths per minute. But wait a minute. We all know that people can breathe faster than 20 times a minute. I've seen really serious patients breathing up to 40 times a minute. Well, how is that possible? Well, here's the answer. You see, it does take time to breathe in and out, and that ratio isn't going to change. So the only way to breathe faster is to decrease the time in which you breathe in. And if you decrease the time in which you breathe in, you're decreasing your tidal volume. And if you remember from the last slide, if I decrease tidal volume, I decrease the amount of air that I can actually get oxygen from because I have to fill the dead space too. All right. So what's all this mean? Well, it means this. When patients breathe too fast, we call that hyperventilation. They're actually moving less air. I know that seems counterintuitive, but it's true. So there's not only a minimum ventilatory rate we look at when deciding on whether to assist a patient. Usually that's about 10, by the way. There's also a maximum number, typically around 40 for adults. So that means that most EMS protocols direct the EMTs to provide ventilatory support to any patient with a respiratory rate of less than 10 or more than 40. You see, at either extreme, too low or too fast, the amount of air moved is insufficient to remove the CO2 that's accumulating or to supply the oxygen that our cells need. All right, I know we've covered some pretty complex stuff here, but as healthcare professionals, we have to understand why our patients breathe and the various observations we need to make to evaluate whether their efforts are sufficient or not. All right, now that's it for this lesson. Take a little break, give it a little time to sink in. If you're having difficulty grasping it, check in with your local instructor, or you can drop me a message.